welcome to Physioplata, another episode. I'm your host, Dr. Patrick, and with me, my co-host, Dr. Rod Henderson. So this is a good one. Let's jump right into it. How was yesterday? Yesterday was a Naga tournament. In Houston. In Houston, right?
Yeah. It was Naga here in Houston. So it's good. It's good to be back here talking to you. Yesterday the 10th Planet crew here at 10th Planet New Caney, we went out to Naga and we had a pretty good time. We had some pretty interesting stories that came from it. We had one of our guys ended up fracturing his orbit.
This was one of your teammates?
Yeah, one of our blue belts, Jesus. Shout out Jesus. Hope you're feeling better today, buddy.
Was that the guy with the video where you were like, he's in an ankle lock or heel hook, he's like tapping
No,
20 times?
No, that was G. Yeah. One of my favorite videos.
Another one.
Yeah, it was another one. But this is Jesus. This guy just took him down, and I'm certain he didn't mean to do it, but just speared him right into the forehead, right into the orbit. Got a good orbital fracture. Went to the hospital last night. Was a little iffy on whether or not he's going to need surgery.
Wow.
So he had quite a bit of bleeding in the socket itself.
Jesus.
And if you don't know much about orbital fractures, that's kind of the big thing. They want to make sure you're not going to have any vision loss or anything like that. So ultimately they decided he would be okay. And so he's okay. So thank goodness. Everybody else came out healthy. I had a fun time. I got put in a pretty tough bracket. And
did you win?
Look, so let me tell you, I'm not going to be dropping any instructionals anytime soon. Just let me finish my story.
Okay.
So it's like I'm not going to have any jiu-jitsu instructionals come out. That's why we're doing this podcast, because I'm not doing an instructional.
Right?
Hey.
That sounds like a no.
So no, it is a no. I lost. I lost
Dude,
quickly.
I'm just joking. Honestly, 100%.
Hey, bro.
The biggest thing is you got out there.
Yeah. So it was fun. I got put in a tough bracket. So the way this works is I'm 51, and in Naga, if you're a purple belt, you go into the expert division.
Oh.
So purple, brown, black.
Wow.
So but then I'm 50. There's really nobody 50 in my age group in there, so they dropped me into this bracket of 30-year-old black belts. Two of them own their own academy, and another's like a big, one of the YouTube guys, Scotty P. So it was going to be a tough bracket. Fortunately, I rolled against a guy named CJ Hancock, who's he's a former Bellator fighter.
Jesus.
He was really. It was a good experience, but it was one of those things where I learned. So we started out on the feet for a little while. I had designs of arm dragging him and getting a rear body lock, but that was all fantasy. I ended up finally sitting, pulling half guard. He quickly moved into a very good part of his game, which is top half. I didn't know that at the time, but top half, snatched up a Kimura. So he did the stuff that you do, only he was successful. So he immediately
sharpen it so much. You have no
dude,
idea.
I've been waiting to say that.
I'm gonna rip it too. I'm not gonna stop. I'm just gonna
waiting to say that for a while. I straightened out and he arm locked me. It was just. Yeah, I would say it's probably pretty boring, but he knew exactly what to do and when to do it. He's a good black belt. But it was a fun experience.
That's awesome, dude.
It was fun. And, thankfully, like I said, we came out of there, Jesus doing okay. And
Yeah, shout out to Jesus, man. Hopefully a quick road to recovery.
Yeah.
Yeah.
It'll be about 12 weeks. So, I mean, most fractures, as you know, a fracture is a 6 to 8 week process. But when you have a fracture that's in a sensitive area, like the orbit and things like that, the timelines are a little bit more conservative. So for Jesus, it's going to be so.
Did they make him a mask?
It's funny because we've been calling him Phantom of the Opera and that kind of stuff. So I don't think so. I think he's going to help maybe teach kids class and do some conditioning stuff. So he'll still be in the game, but
cool.
That's just the way it goes. Jiu-jitsu.
How'd you feel? Because I know you were out. That was the first competition in how long for you?
Yes. So that was the first competition in a little while. As you recall, I dislocated my right shoulder earlier this year.
This year? No, last year.
Excuse me. It was December 31st of last year. So New Year's Eve, where I was New Year's Eve open mat and dislocated the shoulder. And so is May. And so 5 months after dislocating the shoulder, you know, I was able to get out there. I didn't do much, but I got out there. And so shout out me.
Shout out you, dude.
Shout out for me for getting back out there. So it was fun. It was a good time. We should probably talk about the shoulder.
Yeah, let's talk about the shoulder.
Yeah.
Many different injuries that happen to the shoulder. I had one last week.
Tell me.
Okay. So we're going to talk in this video about the differences between what a shoulder dislocation is. We're going to talk about what a rotator cuff tear is and the difference between those two and a shoulder separation.
Yeah, AC.
AC joint. So that's what I had last week.
Yeah. Oh, yeah, AC injury.
Yeah.
You did.
Mm-hmm.
Tell me about it.
Like a grade 1.5.
Oh, Bobo. Okay, yeah. Tell me about it.
Okay, so here we go, right? We're doing the gi, like you should. So, and then we're doing a little takedown battle, and, you know, a little scramble. And I find myself one knee down, one leg up, and then quickly get to both legs up. But my opponent had my sleeve grips, so he had 2 sleeve grips on me. So I had that was if I
no
can
base,
say, dude. If I can say anything, like, do not get anyone your sleeve grips, both of them. That is the worst case scenario. And I was, you know, it was funny because it was a little competitive, but it was a little bit of a flow roll too. So I was just being dumb, got both of my sleeve grips taken, and then he did a little shoulder toss from his knees. So thankfully it wasn't standing up, but I feel like if it was standing, I could have probably just sit my butt down like you do. That was for that Kimura stab, dude.
All right.
But anyways, yeah, so thankfully it wasn't all the way up, right? So, like, still, you know, a good distance up there. But he threw me from his knees rather than from standing. But yeah, he had my sleeve grips, and I landed right on my deltoid there on the right side. I felt it too, felt that little pop there. But I knew it wasn't a bad injury. It hurt. Like, it got sore. You know, had a little difficulty raising my arm all the way up. Had some soreness with that, but I was immediately, I started working on it right away.
Yeah.
Like, just passive range of motion, active range of motion, then some rotator cuff work, some serratus, all that good stuff. So, and now, that happened Wednesday, and today's Sunday. So today's comp class was a little dicey. I was definitely still, like, you know, not getting through all the gears. Tapping a little bit early on some positions because I felt like the shoulder got a lot of pressure.
Yeah.
But other than that, feels good. So next week should be back to normal.
That's good. So you went from a pretty, like you would say, a pretty minor injury, but still noticeable, and but didn't sideline you too much. So that's good. Mm-hmm. That's good.
Yeah. So let me kind of why don't I jump into the AC separation, you jump into the shoulder dislocation.
Yeah, that sounds good. I've got some background in AC separation. I had a grade 3 back in '94, a long time ago. You know, and so I've still got the residual piano key deformity. But yeah, those are very painful.
They suck.
They're very AC joints, very painful. Some of the small joint injuries that you'll get, fingers and such, they're incredibly painful.
Let's talk about that AC joint for a second. Mm-hmm. So we've got, you know, the clavicle that meets then the acromion on the backside there, the little S bone. Yep. And you know, one thing that we learned in PT school that always fascinated me, it's the only bone attaching the entire arm to the body. That is so crazy, dude.
Yeah.
Like, this little bone, and for me, it's pretty, like, superficial here too. So it's, you know, subjected to a good amount of force, like, during guard passes, or if I have to defend, like, a cross-collar choke or something like that, that's a little tender. But yeah, it's just the only bony connection to the body for the entire arm. I got long arms too, so yeah, you know, that's a lot of stress that can happen on that joint.
Yeah.
So, and then, you know, you have your ligaments crossing over that AC joint, reinforcing it, but the AC joint itself is not very congruent, meaning it's not as like tight fitting, like the hip, for example, right? Yeah. So you think about that, like, the whole arm hangs on this clavicle acromion joint, clavicular joint, and it's reinforced by some muscles, it's reinforced by some ligaments, but that's it. So when you land on that shoulder, you know, you got that little push up on the shoulder on that AC joint. If you even, you know, like you did, if you ruptured those ligaments, that is a tougher road for recovery, I would imagine.
Yeah, it does take a while. People don't realize the AC joint takes a lot of stress, and it's a pretty underappreciated joint because you think about, like we're going to talk about dislocations, and rotator cuff pathology, and that stuff always gets the big. The big press,
mainstream.
Like it's like a really big deal. But the AC joint is like the independent film of the shoulder. It just doesn't get a lot of press, but it's very, very painful. And one of the things I noticed when I first started training is people, and myself included, when I was first learning to Granby and invert, I was putting a lot of stress across my AC joint. Of course, that when you first start to invert, you discover pretty quickly that you got to stay off your neck. You got to want to make sure you stay off your neck, but you also have to make sure not to put too much pressure across your shoulders, because people will say, hey man, I'm having this pain. It's always localized pinpoint to the AC joint. That's one of the kind of the characteristics of AC joint pathology is, usually if it's a rotator cuff or capsular issue, people are kind of saying, it hurts in this area. But when it's an AC joint, it's like one finger right there. It's like my AC.
Yeah, and then you get the special tests like the crossbody abduction,
exactly,
pushing, etc. I mean, you basically, honestly, if you're a clinician and you've paid attention in school and paid attention to the reports that people will have when they're talking about the AC joint, all you need to do is listen to his subjective history. And you're already pretty sure about what's going on when that's the pathology, the AC joint.
For real, the AC joint is one of the most cut and dry. Diagnostically, one of the most cut and dry injuries. It's usually trauma, but not always. I mean, sometimes it could just be like you wake up a little bit sore, but most of the time there's a trauma, like in your case, associated with I had trauma, but.
So when you're waking up with it, you're laying on your shoulder and it's crunched, and same thing. Honestly, like a creep kind of sets in, right? That distraction of that joint over time, over hours of sleeping, which is drawn out the trauma basically. I would still call that like micro trauma, like you're just prolonging it when you have a acute trauma when you're falling or being thrown on it.
I agree completely. I mean, and I think one of the things people say a lot, they say, it really hurts at night. Well, there's a lot of reasons for that. One, at night, during the day, you're doing all kinds of stuff, and your brain is distracted by what you're doing, and then at night, you're just kind of laying there. There's really not much you're processing other than what's coming from the body. So pain levels, I think, tend to go up a little bit at night. Plus, you're in one position, relatively static position for a period of time. And that's the best way to make a joint stiff, is to be in one position for a long period of time. So people often wake up and their shoulders really stiff and sore, and they get up, move around. It's a little bit better. But yeah, I do think sleep is that's one of the reasons why sleep and musculoskeletal care is so tricky, I think, because one, from a neural perspective, you're really aware of the pain, and then also from a mechanical perspective, the joints are relatively, they're not moving very much. That's the exact opposite of what we do in exercise, in the clinic, where we're getting the joint moving quite a bit more. That's why it feels better when you move.
I think compression also plays a role into what you were saying, that consistent compression. You've got your bursa there as well, so you can have consistent compression on that, tendons, and then the joints.
Yep. Yeah, for real. But management, so diagnosis is pretty straightforward. Management is also pretty straightforward. I generally tend to think of sprains like AC joint injuries and things like that in terms of just like I would an ankle sprain. It's the same basic pathological process that's going on, but it's just in a defined area of the shoulder. And so, obviously we want to let the inflammatory process try to run its course as unfettered as possible. So I try to keep it in check, but then also making sure doing exactly what you did. So the things that you did, if I say, okay, coach, I just got I just got an AC joint injury, and you start immediately doing relatively pain-free shoulder activities, serratus activity. You said serratus, rotator cuff. I think you could pick any number of sub-pain, movements. And I think it would be a very good thing to do. And a lot of times that makes a big difference early on.
Yeah, I mean, I think it did quite a bit, because I felt it being stiff as well, and it was getting more achy because I had difficulties raising my arm higher to stretch it out, so to say, and loosen it up. So I jumped on the pulleys first chance I got. just get some range of motion, just warm it up, just get it moving.
So you did the rope and pulley? Like
Yep.
just kind of, yeah. Dude, that is such a base.
It's so underrated.
It's such an underrated shoulder rehab tool. It's just a rope and a pulley, and you just
people
going
get
up
mad.
and down.
People
It's
get
so
mad.
boring.
For people who have shoulder injuries, and if I warm them up on that, I gotta like sell them all the time on it. It's like
so boring.
Yeah,
It's so
don't get me wrong, it's boring, but it's like almost for me, it comes into like almost like this comparison to like the Japanese culture. You gotta appreciate and love the process, like every little, like for example, when they're building structures, every little corner has to be perfectly fitted onto the next and stuff like that. And that's what I'm saying. It's like people go through the pulleys like crazy, and they just like jam it up, like their thumb is doing all kinds of stuff as they're like, you know, raising the roof or whatever dance move they're making on that pulley. But I'll tell you, anytime we're really like doing that consistently, the range of motion stays really good. And it's a valuable tool for many different shoulder pathologies. Even if you have full active range of motion, sometimes just putting a few minutes on that does a lot of good.
Still do it. I think the rope and pulley is a really nice tool. It's very cheap too. So if you've got if you do jiu-jitsu, and you know, it's likely that you're going to encounter some sort of shoulder problem at some point down the line. I think a rope and pulley is just one of the easiest things to go ahead and collect for your home exercise equipment. Shoulders feeling stiff, little rope and pulley, super basic, super easy, but I definitely think it is like a major player in shoulder rehab.
I think so too. Just like the bike for the knee, like the knee is just, I mean, you can get the resistance way cranked up, right? And then it's not such a good thing for your knee and hip probably, because your quads get real tight, you get a little more compression and you bypass what it's supposed to do. But just that reinforced range of motion that's very light and it's very easy to do. For me, it's the same thing. Pulleys for the shoulder, bike for the knee and hip.
I don't disagree with anything you're saying, and I probably disagree with you on a lot of things, but that is definitely one of the things I do. I think, you know, just that gentle range of motion, sub threshold, sub pain, not cranking on it. It's just rhythmic movement. Great stuff to do. So
great start.
Yeah. Good start for the shoulder there.
So let's talk about maybe whatever thoughts you have, just throw them out. But I was thinking maybe why don't you talk about what the difference is between a shoulder separation and a shoulder dislocation?
So it's a real common misunderstanding. So people say I separated my shoulder. Some people, and so they use the terms separation and dislocation interchangeably. Whereas, as you of course know, the terms a shoulder separation and a shoulder dislocation, two very different things. We're talking about shoulder separation. We're usually looking at the acromioclavicular joint, so the joint we were just discussing, the connection between the collarbone and the shoulder blade. So it's typically characterized by pain right on the top of the shoulder. Most of the time there's trauma, but sometimes it can be kind of a little bit of a milder type of sprain. When we talk about dislocation, we're usually talking about some sort of disruption of the glenohumeral joint or the actual shoulder joint proper, the ball and socket of the shoulder. These types of injuries are a little bit more severe. In other words, they take a little bit longer time to recover. They can be medically or surgically more complex, especially if they keep dislocating. There's shoulders that are traumatically dislocated. Like in my case, I had a traumatic dislocation. And then there are some people that have a thing called multidirectional instability. Those are not really what we're talking about here. We're talking mostly about the traumatic type of TUBS dislocations, into that type of instability where you have a one-time dislocation, and then you can either have it, in my case, mine reduced there on the mat, but sometimes it has
Which
to
is
be
best
reduced.
case scenario?
Best case scenario, to have it reduced spontaneously like mine did. But in many cases, you go to the EC and they'll reduce it manually. And then the question is, well, it's a scary thing. It's painful. Your shoulder will be sore for quite a while afterwards. Then the big question is, are you going to have recurrent instability? Are you going to be somebody who spontaneously dislocates? Or are you going to be somebody that has a dislocation, but then they don't experience that repeated instability?
And I think that kind of partly depends on what other structures are damaged that first time you dislocate it, right? Because it's like a clean dislocation, and then relocation, that's base case scenario like we were talking about. But if you fall like on an outstretched hand or something like that, get some rotator cuff involvement there too, then it becomes more complicated. And then
it can. And, I've got a good buddy of mine. As a matter of fact, I just talked to him on the phone a few minutes ago. His name is Hugo. Shout out Hugo. He's a serial.
Is he a boss?
Yeah, he's got, no, he's not my boss.
No,
you
I'm saying Hugo boss. You don't know.
Oh, yeah. No, terrible sense of humor. So, Germans. So, he dislocated his shoulder and then, recovered pretty well non-operatively. But then he kept experiencing kind of recurrent dislocations. And so those are trickier to manage. He's a young guy. So generally, it's most of the case, old guys or old people, they don't usually like to do a lot of surgical interventions on. So they would be more likely to let my shoulder go. If you're in your 20s, 30s, and you're still very active and you're just dislocating your shoulder, you're probably going to be a little bit more of a surgical candidate. And the surgeries for that, for recurrent instability, based on my understanding of the literature, the surgeries do well.
They do well.
Yeah.
I think I can concur with experience on that as well.
Yeah. So that's one of the few cases where I will advocate for, making sure you get to a good surgeon who can take care of that recurrent instability that you're having. If you dislocate your shoulder, you keep dislocating it, get it taken care of.
Yeah, I agree. That reminds me of a story I had in the clinic once. There was this guy. I think he was supposed to have surgery because he had dislocations, recurrent ones, and this was right before COVID. And then COVID hit, and he put it on hold because obviously, you had only the surgeries that were like life-saving surgeries that were allowed here in this area. So he put it off, and then he felt like, I've been dealing with this for a while. Maybe if I get some PT, it'll be getting better, and I can bypass the surgery or not get it. And unfortunately, he was definitely a candidate. I sent him to a surgeon, or referred him to a surgeon after his eval, because he would literally externally rotate his arm by like maybe 25, 30 degrees, and then he had to stop because if he'd go further, he'd dislocate it.
Yeah.
And then there's other directions that he had that same problem with. He couldn't raise his arm past like chest height. So, there's a lot of stuff going on there. So. But he did really well afterwards, like no problems. Yeah,
they do well. It's one of the few, like I said, one of the few instances where surgical management, I'm like, maybe, if you keep dislocating, Hugo, I still think he hasn't had surgery yet, but because he does very well, he recovers well. But then, if you slap his arm in a really strong Kimura, or if you put it's
that's not cool.
And it's the uncertainty of it. But the recovery after the reconstructions, they tend to go. They're kind of boring, and it takes a while to get to go through that.
I think it's like
process.
This is I think maybe one of those examples where I had the experience of patients or clients typically progress really fast, and you got to put the brakes on them, just because like the labrum and other connective tissue muscles are healing still from the surgery, so they're in that like vulnerable state, even though they don't feel that. The pain is mostly gone if they have any at all. The strength is coming back really well, but again, right, it just takes a little right angle, and then you have the same problem. And then the surgery was for none, basically.
Yeah. And unfortunately, I don't know what I'm supposed to talk on. I've not had a patient, re-dislocate afterwards.
Nice.
But yeah, the instabilities and dislocations are tough to manage. If you're going through this process, just be ready to be patient. Because you're going to feel like you can push harder than you actually should. So like at 6 weeks, the surgery, the pain from the surgery is going to be relatively low, and you're going to feel like your shoulder feels kind of stiff, but that's the right thing. It should feel a little bit stiff, and you gradually expand your range of motion out from there. You gotta go easy.
Tell me about how you felt. Did you have any uncertainty? Did you have any queasiness, any nervousness about your shoulder during that tournament yesterday?
Yeah. I still, there's still in my head when I get into that shoulder crunch position, I get a little bit nervous. So the last couple of weeks, I've put that arm in a shoulder crunch situation, and I still think that injury was so fluky because I was fighting hard against the shoulder crunch. If I'd gone with it, it would have been fine. But I was just being very stubborn. So I put myself in a couple shoulder crunch type situations, and it did fine. But yeah, I mean, it's one of those things where the possibility of an injury is the specter of that is always out there when you go to do jiu-jitsu. And
any other sport too, though, I will say, even daily activities, dude, you can fall down some steps, you know, boom, there you go.
But the stories that you have, and the upside to doing it and stepping out there on the mats, I still think outweigh the downsides, and so you just have to kind of do that math and decide, well, you know, exactly. I think you could walk outside and trip down a flight of steps and have the same exact injury.
I'm telling you, I can't tell you how many people slipped in their driveway. And they had either a fracture or a rotator cuff tear, and then, you know, just stuff happens, man.
Yeah.
But yeah, let's not forget that if you do jiu-jitsu, you have, you know, the risk of having an injury, but you know, there's other factors as well.
Yeah.
So what do you think about your performance? Was it limited by your shoulder at all?
No, it was definitely just limited by the fact that my opponent was way better than me, and you know, he just thankfully, you know, I had this injury about 5 months ago, and at the time, I remember feeling very, very frustrated and angry, and you know, all the things that you get when you have an injury. You feel like you're not going to be able to do the things you love, and all that stuff was just total bullshit. I was fine. It was going to get better. Things get better. You know, you just, a lot of times you just kind of have to wait it out and just be persistent. It's kind of like jiu-jitsu. You know, it's your classes as a white belt and maybe early blue belt. They suck because you're always getting beat. And you're just like, what do I do about this? Well, you just kind of keep going, you know, and you just keep showing up, and you know.
You gotta be mentally there, though, because I made this mistake when I first started as well. Like I did watch, you know, some instructionals. I did watch some YouTube guys like Chewy from Jiu Jitsu. Shout out Chewy. So, you know, but Chewy never said this, but other times I've heard before, like, okay, you just got to show up. You just got to show. Sometimes, like, you know, upper belts would tell me, hey, you just gotta keep going, keep training, and that's 100% true. But you can't just go be there physically and not be there mentally, because you're wasting time and your body is not progressing, or your jiu-jitsu game is not progressing the way it should at the same rate, because you have to study it just like everything else. Like, you have to understand the movements, you have to mentally think about them and ask the question why, and then kind of like problem solve through it, because I was always like going in and doing drills, but only doing one move, right? So I would do armbar drills, I would do triangle drills, but I wouldn't put the whole thing together, like trying to find an entry to that position in the first place, then trying to set it up, then trying to close it, and then finish it and submit.
And then what to do when it doesn't work.
And what to do when it doesn't work.
And having that insurance policy of what to do when it doesn't work out. You know,
exactly.
It gives you more confidence doing the technique.
Yep. And it's normal, you know, for white belts, people just starting, to make total sense. You go through that period, but you can shorten this period. You can shorten the suffering if you're studying it, to try to understand what's going on, why things are the way they are. Ask questions, stuff like that.
For sure, and I'm very much that way. I'm very much all into jiu-jitsu. I'm constantly watching instructionals, for better or for worse, you know. And I think it helps me. It helps me some. It helps me actually a lot, I think. But you know, I do think I agree with you that showing up is definitely a minimum requirement. I think you can make it a lot better by you know, doing all the things we've talked about so far, studying, taking care of yourself, getting good night's sleep, getting good recovery. There's very basic stuff, but yeah, I think it all helps.
Yeah, I think for me the problem is I'm a very kinesthetic learner. I have to do it to understand it. So that means I have to put my body through so many more reps.
Yeah.
And I'm trying to get to the point where I can like just pay attention to what I'm seeing and just be more of a visual learner too, because you need it. You need it. You can't just be one type. I mean, you have a preference, right? But you can't just rely on one type of learning when it comes to something that is so complicated, like jiu-jitsu, wrestling, anything like that.
Right. Yeah. I agree completely. It's you've got to be able to. I mean, this is not easy. This is not easy. Like I said, if it was easy, it'd be your mom.
It was what?
Just kidding. It was a joke. We can cut that out
Okay.
later. I said if it was easy, it would be your mom.
Is this what you guys
It's
talk
a funny.
about
No,
in
it's a
10th
funny
planner?
joke. It's if it was easy, if jiu-jitsu was easy, it would be your mom.
Okay.
You know, no.
Mom's, I have not heard of. That's why I was so
That's
confused.
like your mama
I
joke.
haven't heard a mom's joke since I watched like
7th grade.
like what's that movie with the football teams? Remember the Titans?
Yeah.
Dude, that's how old that joke is.
That's how old I am.
No, you're way older than that.
I'm older than Revenge of the. What is it? Clash of the
Remember
Titans.
Remember the Titans, man.
That had Harry Hamlin and Burgess Meredith.
I just remember Denzel.
Clash of the Titans.
No, Clash of the Titans. That's that. Whatever, man.
You say
Anyway,
it's that Sam Worthington movie.
let's get back on track. Get back on track. We haven't talked about rotator cuff tears yet. Or
Okay.
injuries.
Okay. Yeah. Let's talk about Worthington.
Yeah. Let's get that part going. So, well, let's start with the 4 rotator cuff muscles. If I can muster up the memory bank on that.
No way you remember this.
No way, huh? No way. Like, well, we got the supraspinatus, we got the infraspinatus, we got the subscapularis, and the teres minor.
Bam.
Boom.
Nice.
Dude, I was in
4
my
horsemen.
clinic. Yeah. I was in my clinic doing rotations way back when, and I was able to rattle them off because I had learned them like at the kinesiology program I was going through.
Yeah.
And dude, that was
Somebody paid attention in anatomy. That's good. So, but it's funny though. You get, I think, of all of the 4, of course, the supraspinatus and the infraspinatus get the most attention. The subscap, I think, is probably 3rd, and no one ever talks about teres minor.
No.
Poor teres minor.
Yeah.
Yeah.
Why do you think that is?
No, I don't know. I have no idea. I've had so much, attention on the supraspinatus and infraspinatus and the subscap, especially treating with like anterior dislocations and stuff. The subscap gets involved with those.
Man,
So,
I think out of all of them, the subscap needs the most love. It needs the most attention and work.
it should.
Yeah.
It's not enough love on the subscap.
No.
Yeah. But the cuff in general, I found rotator cuff pathology. It's obviously if you treat people with shoulder pathology, you're going to spend a lot of time working with folks that have rotator cuff injuries. It affects, it's across the lifespan. The young kids get it, and then as you get older, you start getting degenerative cuff tears and things like that. So taking care of the cuff is a big part. It's a big part of the shoulder, your shoulder maintenance.
I think I see the degenerative types the most in the clinic. And then you've got your traumatics here and there, right, with whatever trauma they had. And I feel like, though, the nice thing about that is that it's a group of muscles that are very good at helping each other out if you just make them do that.
Yep.
And so I typically don't have any issues with, knock on wood again here, don't have any issues with people who come in to see me for a rotator cuff injury and or had even surgery, because there's lots of muscle support that can make up for a tear here or there. And what do you think about the research? I have not brushed up on that as much, but what does the research say about the tearing and the healing of that? Because last I heard, this is what I heard, or this is what I remember from looking at the research and stuff.
You're going to make me get on a soapbox here. Go ahead.
Okay.
I think I know what you're going to ask.
Well, do they heal?
Yeah.
Okay.
Yeah, that's a good question. The data that appears to be fairly consistent right now is that, once you have a tear, and even if you have a repair, after 5 years, the repair or the tear hasn't changed a ton. There are definitely morphological changes that occur within, the muscles, but everything in 5 years, everything changes. The really interesting data that I've seen is on rotator cuff repairs. So you take a group of people that have had rotator cuff repairs and then re-examine them at 3 or 5 years. You're going to see people that are doing mostly well with their shoulders. Their shoulders are functioning pretty darn well. But the re-tear rate is pretty high. It's 30 to 50%. So you're looking at people that even though the cuff has re-torn after the repair, the shoulders are still doing well. So it goes back to what you said earlier, where you think, okay, you have a rotator cuff tear, but then the other cuff muscles kind of chime in there and they help out. And it's like that Jurassic Park Jeff Goldblum thing, life finds a way. You know, that kind of deal where it's like your
Which
body
Jurassic
just
Park are we talking
the
about?
first one, the
first
the
one,
real one,
OG,
the real one.
Of course, that's the only one you remember.
It's like 1992, I think. I think so. 19, Patrick, what is that? 92? That's 92.
Yeah, nice.
Yeah, it was 92.
Nice.
Yeah, shout out Patrick. But yeah, so it's. I think a lot of times your neuromuscular system just starts to reorganize around whatever environment it's in over a period of time. And so that's really in rehab. That's what we're trying to take advantage of, that reorganization process. You can't really pin your expectations on the structural integrity of the cuff, because I guarantee you, if you look at my cuff right now, if we were to look at my rotator cuff, it's not going to be pretty.
Well, I think also that comes back around to what we said in previous episodes, and I'm going to say it again. I think if you have a shoulder pathology and you haven't spent at least 2 or 3 weeks on trying a conservative route like physical therapy, and you're jumping straight into surgery, you're doing yourself a disservice. And because number one, you have to have PT most of the time afterwards anyway, and exactly of what you were saying, like the tears, that they're just as common in the shoulder, I would say, and you can tell me if I'm right or wrong on this, but I think they're just as common in the shoulder as disc bulges are in the back.
100%.
Yeah.
They're almost just like, after a certain age, it's when someone tells me that they're 30 to 40 years old, they say, I got a herniated disc. It's like, man, everybody's got a herniated disc at that point, you know?
It's like saying I have 2 thumbs.
Right. Yeah. It's like we've all got these things. And so that's just kind of it's just part of the aging process. It's like you get wrinkles on the skin, you get wrinkles in the body as well. And so that's kind of how things break out. And the question is always how much those things are contributing to the problem that you're having. And most of the time, if you come to me with a shoulder pathology or rotator cuff involvement as a healthy young guy who's active, I'm not really concerned that this is. I'm not really concerned about your prognosis. It's the patient that comes in. It's very apprehensive to move, maybe has some comorbidities, particularly in the shoulder, diabetes, or the metabolic syndrome, and those types of things. I'm more concerned about those patients, and sure enough, that's the literature bears that out as well. If you're healthy and you have an injury, versus if you're unhealthy and then you have an injury, the prognosis are just, they're so different. And the same injury, but they just happen to 2 different types of people. The healthier person's almost always going to recover from that injury better than the unhealthy individual. And it's just one of the cases that I try to make to people. It's like, look, I don't care how you do it. Take care of yourself. Be healthy. Some kind of exercise regularly. And that's going to make whatever tragedy happens in your life, whether it's orthopedic or otherwise, it's going to make that outcome better. And so cuffs are the same way. Well
said. So you were talking about diabetes, and that just brought something into my mind. And we should probably talk about that, since we're talking about most of the things with the shoulder and things that can go wrong. And typically this doesn't happen to someone that's younger, and most of the time not to people who do jiu-jitsu and stuff like that. But let's talk about the frozen shoulder.
Yeah, stiff shoulder.
Do you want to jump on that?
Yeah.
What's the definition of that?
Yeah.
I'm curious to hear your point.
Yeah, so the frozen shoulder, I've almost stopped. I've kind of moved away from using the term frozen shoulder just because
I don't at all anymore.
It's the common term, so I use it when everybody else is, if the patient's talking, I got a frozen shoulder. But it's just basically a stiff shoulder, and a shoulder that gets abnormally stiff, and that can happen. You can get a primary adhesive capsulitis or frozen shoulder, stiff shoulder, and that it just, you wake up one day and your shoulder is stiff and painful, no good reason. In many cases, those patients are a certain profile. They're diabetic. They're perimenopausal women. So diabetic perimenopausal women that's like the golden child of idiopathic primary frozen shoulder. And they're terrible. They're
tough. They're really tough.
They really are tough.
Get better.
There's really no. It's like a why me type of thing. You know, it's like, I can't believe I'm in this much pain. I didn't do anything to cause it. It really, really hurts. And then our management of it's not that great. You know, we're like, oh my God, we got to get you. You know, everybody's kind of running around with their hair on fire, trying to fix things and help you feel better. And then the orthopedist will tell you to really be aggressive with the range of motion and that kind of stuff. And that's terrible.
Never works.
It's just really terrible idea to take a really sore.
Sucks for everyone.
It sucks for everyone. But patients are screaming. My early management of frozen shoulder is so jaded. I was so frustrated as a younger clinician trying to manage idiopathic, primary idiopathic capsulitis. It was really, really tough for me. And then after a while, something happened, and I just said, "Look, I'm not going to do this to you. We're not going to keep cranking on your shoulder.
Yeah.
And you cry. You go home. You come back. You got the same range of motion, and we're going to do it again. Or worse, sometimes worse. And then we're going to do it again. We're going to do it for 6 months. We're going to spend all this money. And if all we do is send you home and give you reasonable guidelines as far as what to do, come see me you pick an interval, and we'll make sure that you're making steady progress, and the patients are doing better. And it's just so those, and then there's the shoulders that you have rotator cuff surgery, and your shoulder gets stiff. And that's a little bit of a different type of problem, although diabetics tend to be more prone to that as well. But it just takes a little bit longer.
I think that's the only time I would use that definition of, or that verbiage of frozen shoulder adhesive capsulitis is either if they're one of those few, categories of the population that they fit in, they really have, and they gotta have that capsular pattern of, mostly restricted external rotation. If they're just like that, then I'll say, okay, you got frozen shoulder, you got adhesive capsulitis. We'll talk about that stuff. But other than that, I mean, I've seen, and I'm not sure how you are with your referrals, but the referrals I get from some physicians, like all the time, is like frozen shoulder, frozen shoulder, frozen shoulder. It's not at all what they have. Yeah. Sometimes they come in with full range of motion frozen shoulder. It's like, we got to talk about this a little bit. So,
well, it's great. It makes you look like a miracle worker when they do that. The patient has a frozen shoulder, and then 2 weeks later, they got all their motion back. You're like, look, I fixed this frozen shoulder in 2 weeks.
Yeah. Well, and it's just much heavier on the educational piece up front, you know. Sure. And it's with frozen shoulder in general, that's the case it goes, or the way it goes. But for adhesive capsulitis, the real deal, there's lots of education up front, just how to manage, what to expect. Because like you said, because you started in the old school days too, where that was the main thing. It's just like push it as hard as you can. Yeah. Put them like on the pulleys, but add like 50,000 pounds on the other end to rip the arm up.
It really was.
It really like that that's what it came from you guys, that physical terrorist. That's you guys.
No, for real.
And now my generation's got to work on this. We're not like this anymore. We're not like this guy anymore.
Yeah, you guys are soft. but for real, so I started as a tech in 1996. That's why my first tech job was 96. And I mean, these patients would come in and they'd be howling. The therapist would be behind the curtain and we just leaning on
behind
them.
the curtain too, huh?
Oh yeah, for real. And,
no visual.
Dude, it was terrible. Yeah. You just hear the screaming, and I hated it. I did not like that. I didn't, and I would be like, well, if we were making progress. But we're not, and that's like fits all my criteria for torture. I was like, this is torture. I'm torturing this patient. They're coming back. They're paying me money. I'm putting them through all this shit, and then they come in. They keep coming in, and they keep putting up with it, and they're not getting anywhere. It's like, why am I doing this to this person? So, backing off, letting nature for stiff shoulders. They tend to have a pretty predictable. Yeah, I don't like the frozen, freezing, thawing metaphor because none of that stuff happens. But there is, there's a pretty predictable, irritable stage, and then it plateaus, and you're stiff for a good period of time, and then it slowly resolves. You can have somebody with you during the process, guiding you, but you don't need someone coercing the arm.
Yeah, honestly, It's hard to say because it's so individualized, and it has to be really tailored to each person when they are going through that kind of problem. But I think just starting with something like the pulleys again, coming back around it, dude, just and then just work in the range that you have. You do not have to put yourself through that torture of, especially if you're not gaining any, like you said, like if you gain and it doesn't last then more than a few hours or the next day. I mean, and it's just minimal. Just work in the range that you have and cause yourself less punishment. So that helps a lot. Just continuous motion during the day, I think, is one of the best things to do in that case, and especially in that inflammatory initial phase of the adhesive capsulitis and stuff like that. And like, I think you got a good idea about the spreading out the visits with the PT in that case. Especially if you're not making the progress in the sessions themselves. I think that's a very valid thing to do, and just make sure that you are keeping them accountable too, because it can get worse. Like that's why they started that, right? Because people stopped using their arm completely, and they couldn't lift it anywhere.
100%.
And that's why they got so crazy about pushing that hard range of motion, no matter how much pain they had and stuff like that. So
Yeah. So I do, and I don't think that there's an ideal interval for everybody to be seen. Some people need a bit more accountability. Yeah. Some people need less.
Totally.
But yeah, it's definitely, I think that our care of this problem is evolving still. And,
I think
it's
so.
been evolving since, it's almost been 30 years since I started working in the clinic. So, it's been evolving a lot since then. But yeah, so for jiu-jitsu players, we don't tend to experience that as much. One, because there's not a ton of diabetics that are in the jiu-jitsu, or at least not the acquired diabetic. I'm sure there's plenty of type 1 diabetics that do jiu-jitsu. As a matter of fact, I know several. But,
do you really?
Yeah. And management, that's always tricky. But you don't see a ton of type 2 diabetics in jiu-jitsu.
Yeah.
So we don't usually see a lot of stiff shoulders.
And type 1 is a whole different level. It's like, I just have nothing but admiration towards people who have type 1 diabetes, and they're still competing. They're still, and not just jiu-jitsu. Like I've known type 1 diabetics or people who have that, and they've done basketball,
endurance,
soccer,
athletes,
but especially jiu-jitsu, especially that's badass.
Yeah. It's really cool. And people do this sport under. There's people out there that do jiu-jitsu without arms, without legs. There's people that do jiu-jitsu
without brain. That's me.
Yeah. Sometimes, for sure.
Meathead.
Yeah, definitely.
Dude, I'm telling you, if I just go harder, I can get there.
Yeah.
If I just go push harder, if I just pull harder, I can pass.
I would strongly recommend you continue to do that with me.
Yeah.
Keep taking that.
I'm going to snatch that Kimura on you.
Yeah.
Trust me.
Yeah. Well, the law of averages is going to kick in at some point for you. And I think, it's going to come. I believe in you. Yeah.
So when is the next competition for you, man?
Well, I've got a possible, I think I don't have an opponent yet, but I've got a sub hunter in a couple months.
Submission hunter?
Yeah. And I'll probably try to do another tournament if I can, just knowing that it's tough to find guys in my age and experience bracket that compete in local tournaments. But what about you? When are you
most of the time you're having to go into the adult division? Is that what you're doing?
Usually they'll back me down because there's just not a ton of 50. There's the 50-year-old guys that compete. Shout out Frederick. There's just not a ton of them.
So what masters are you? Masters 12? Masters 11?
I'm what they call executive. So
that's hilarious. That's awesome. I love that.
Middle finger to Patrick right now. Middle finger to Patrick.
One, dude.
See, I know what you are.
I have like there's often there's no opponents, so we got to go to adults, and that sucks. But it is what it is.
Yeah,
it's not all that different for me. I'll be honest with you. I was happy about that Masters. Group.
So you're what? Hang on. How old are you now?
I'm 32.
Oh, so you're 32. That's a Masters one.
Yeah, Masters one.
Okay.
Right. What is executive? At what point? Masters goes to 4 or 5?
So there's different conventions, but on IBJJF, which, whatever, I think I'm going to be considered a Masters 5 or Masters 6. I can't remember which, but it's, getting up there.
Nice. That's awesome, dude.
Yeah, it's fun. Try to get out there and have a good time. And, my expectations, I'm not trying to do ADCC stuff. So
You are?
No, I'm not trying to do ADCC. No, absolutely
whoa.
not. I've got zero aspiration. Well, I mean, I'd love to do the Opens. That'd be kind of a fun experience, but...
Isn't it funny how, like, each tournament is, like, a different culture and style? To me, like, Naga is the Wild Wild West, man.
Yeah.
It really is. Like, they give you a sword and shit.
Yeah.
I mean, like you said, I had no idea that purple belt is with brown and black belts.
Experts,
that's crazy.
Yeah, that's wild.
That's awesome too on a different side of things. If you're really trying to test yourself and you've got a really solid, submission game. And then IBJJF is like this prestigious thing.
Yes.
It's
Very more
shiny, very shiny.
Yeah, very more like a country club kind of a feel to it.
Yeah, you got to have a membership, and then you pay for the tournament, stuff like that. And they're all over the country. And then you got other things like here you got the Houston Jiu-Jitsu World League. I like that one. That's a really cool one.
I haven't done that one. I've heard that was a good promotion.
They're every year they're getting better and better, and having they're really really good towards the athletes. They're doing a lot of nice things.
When's the next one?
The next one is going to be here in Houston in June. I don't know when exactly in June. Beginning of June, I think.
Oh shit. What do you got to do? Are you competing?
Dude, I'm thinking about maybe competing at a IBJJF tournament.
Okay, cool.
I think that's the next one for me. I haven't done any tournaments this year. Typically, I try to do at least one a year. How many do you do a year?
Well, the last couple of years, I haven't done that many.
Yeah.
But I try to compete 2 to 3 times a year.
Yeah.
This year, I'm going to try to compete a little bit more. I just got my purple, so I'm wanting to compete a little bit more, and just try to put myself out there a little bit more.
I go by the saying that you should have one competition per belt. I think that's a valid point. I mean, I think it's nice if you do that, but I 100% agree with anyone who thinks the same about doing at least one tournament while you're training jiu-jitsu.
Oh man, yeah, absolutely. You don't have to, and of course I'm not.
No, you don't have to.
So, but the process of competing, I can't say that I enjoy it, because it's nerve wracking.
Yeah,
you
that's
step
why
on
you
the
do
bats,
it though.
But yeah, I come at on the. Like today, I feel more focused. I feel like, I'm a little salty about, losing my match. So I'm kind of like, I want to work on my bottom half,
That's why it's so awesome though, man. Like, I mean, for you, it seemed like a different situation with upper belts, and that's tough because your game is never going to be as good when you're going up on the belt rank against higher belts, right?
But better, yeah.
That's kind of awesome because you pressure test your skill set, your stuff. If you can do it, pull it off in a competition, it works.
Yeah.
No ifs or buts about it. It will work.
Yeah.
And I think that's what is so beautiful about jiu-jitsu. I mean, obviously you have other martial arts that kind of have the competition thing, and you compete against other people. And if it works, say you win, then obviously you can anticipate it working in any scenario, right? But jiu-jitsu is one of those things where you can train hard on, go full on, more times during the year where you're not having to worry about other things like concussions, broken bones as much. It happens, right? It happens,
yeah.
but that's not the majority of times when you're comparing that to striking arts, for example.
Yeah.
Boxing, karate, whatnot. So what I think is awesome about it is that you can do it multiple times a year if you choose to do that, and you can really pressure test all of your stuff, and that's awesome because if you have martial arts where you're not pressure testing your techniques, I mean, we're not the ones to talk about that. I'm just going my little soapbox here, but
I agree.
Dude, if you have like a martial art and your guys are never going like full speed, I don't put much value into that.
Yeah. It's if you're not
unless you're just doing it for the art,
exactly.
That's perfectly fine. I don't have any problems with that.
Yeah, that's cool. But I do appreciate jiu-jitsu for the fact that we regularly pressure test this.
Yeah.
It's kind of like, hey, the mats don't lie.
In all kinds of different environments too,
Yeah.
right? No-gi, gi, different weight classes, ages, sizes, stuff like that.
Yeah, and it's fun. It's a good time. Jiu-jitsu is a great sport, man. That's why we love it. That's why we're doing it. That's why we're sitting here.
Yep.
So anyway, man.
Speaking of sitting here, Shout out to Revolution Dojo in the Heights. That's where we're at right now, and just doing the episode again here. And shout out to Cross Collar Jiu-Jitsu. That's my old school where I was right before this. Shout out to 10th Planet.
10th Planet, New Caney.
Shout out to who was it again?
Jesus Garcia. Yeah, Jesus Garcia. Yeah.
Wishing you a fast, speedy recovery.
Yeah. Shout out 10th Planet. Shout out Lonnie Vickery. Patrick, really appreciate Patrick hooking us up today with the audio
all
visual
good
stuff.
Things come from Patrick's, man.
Yeah.
St. Patrick's Day, you know what I mean?
Yeah.
Guys, if you like the content, we would really appreciate you guys leaving some comments, just leaving some questions, anything you want to hear more about. We want to hear that stuff from you guys so we can tackle that and give you some information that you're interested in. And if you like the content so far, leave a like if you're up to it. If you want to subscribe, that'd be awesome too. And that'll be it, man.
Yep.
So another episode in the books. Again, I'm Dr. Patrick. I'm your host, and my co-host right here, Dr. Rod Henderson. And keep training, guys. Hang in there. Work hard.
Y'all take care.
Till the next time.